So I want to thank MGMI for inviting me to speak again this year, and I want to thank all of those who are joining in attendance. It had been my intention to join you in person. I was asked to chair a discussion section today, and that discussion is on myasthenia gravis, and so. The board was kind enough to allow me to present virtually, and I'm hopeful that I can do the topic justice in this fashion. I'm just very appreciative to continue to be able to give this talk. I think it's so important. So my name again is Amit Sachdev, and I serve a couple of different roles at Michigan State University. But the most important one to this audience is that I run the Division of Neuromuscular Medicine, which means that I think about nerve and muscle diseases all day long. I am also the director of our Muscle Dystrophy Center of Excellence. That's funded by the Muscle Dystrophy Association. And as a part of that, we care for patients with rare inflammatory and genetic nerve and muscle diseases. And that's where the myasthenia program comes from. And so my gratitude to the Muscle Dystrophy Association for their continuing support. My gratitude as well to the sponsors of today's event. You know, these events don't just happen. There's a clear commitment to the disease state and to education. And the clinical trials that we're going to be talking about also reflect that commitment. The clinical trial program for myasthenia at Michigan State at present has about a half dozen studies. And we are going to be opening an additional 7 studies with 7 unique medications to try to treat this disease over the course of the next 18 months. So those are all experimental, of course, but to have 7 new treatment approaches that think about the disease treatment in different ways, and to try to find the gaps, right? Seronegative patients, patients with MuSK, patients with LRP4. How do we care for these patients? I mean, these trial programs represent that commitment, and you can't do it without the sponsors. So again, thank you so much for that. So some housekeeping. First off, my disclosures. I am a trustee of MGMI. And I serve on a number of other boards and organizations. I do receive grants and from a number of pharmaceutical companies, including some of the companies that have sponsored today's event. I do consult and I do speak and educate for some companies, including, again, some of the companies that have sponsored today's event. The entire talk is going to be either off-label or experimental use. And so that means that the FDA has not reviewed these therapeutic strategies for this disease, and there is not a guarantee of benefit. There is, for these drugs, risk of harm. And where I can quantify that risk, I've tried to do so. That is true of clinical trials. There's a clear risk of harm. There's not necessarily a guarantee of benefit. And we just don't know until we do the studies. As I think we heard at the Q&A session with Dr. Salgado's talk, some patients don't have access to treatment options. And the clinical trial programs do reflect an opportunity to gain access in some cases. And so those are really the populations. That's why we do this. Okay. Confidentiality agreements. There are some questions, unfortunately, I'm not going to be able to answer. And that's because companies have shared with me scientific information that is not public. They're trade secrets. They have shared that with me because I work for the university and I help them run their clinical trials at our site. And in order to understand risk, I need access. But because of that, there are just some questions that I can't answer. I will do my best to answer the questions that I can. This next statement, it doesn't really apply to the present audience, but we do distribute this video on the website, and there are people in the investment community who may be looking at this talk and listening to it. And if you are in the investment community and trying to figure out whether or not you should invest in a company, my opinions don't reflect clinical trial results. And I do have personal investment strategies. They're called mutual fund managers. So I don't invest in this area. I don't play the stock market or anything like that. The mutual fund managers do all of that. And so I wouldn't make any suggestions about investing based on anything I say today. And that's just a housekeeping note. Uh, so you're going to see that I've labeled this Act 3. What you're going to be seeing is slides number 60 to 100 of a 120 slide deck that I have on myasthenia gravis. And so you don't have to hear all 120 slides because Dr. Salgado and the other speakers have really done a wonderful job talking about some of the other topics. So Act 3 in this slide deck is emerging therapies, clinical trials. So clearly current therapies are helpful, but they're not perfect. So the question is, what else can we do? And then what do failed clinical trials or terminated development programs teach us? So we're going to start with the current treatment landscape of myasthenia gravis. And so this is how I think about it. And so this is essentially Dr. Salgado's talk synthesized into one slide. And so there are 4 different treatment approaches for myasthenia. The 3 to your left, these have to do with your immune system, and the 1 to your right has to do with just tuning up the way the nerves talk to the muscles. So when we think about the immune system, this is an antibody-driven disease. So the body makes antibodies, and those are usually beneficial, right? We take our vaccines, COVID or flu or shingles, in order to get the body to make antibodies. And in myasthenia, those antibodies are disruptive. They bind to the neuromuscular junction and they block the ability of nerves to talk to muscles. Well, one approach, and this is the one to the left, allows that antibody to be made and allows that antibody to flow in the bloodstream and allows it to bind against the nerve or the muscle, and then tries to stop it from doing things, kicking up inflammation. So that's one treatment approach, and that's prednisone and complement inhibitors. In my mind, that's how those drugs work. Leave the immune system intact, allow the antibody to live its life cycle, allow it to bind, keep it from doing bad things. The second approach is to, again, leave the immune system intact, but stop the antibody before it can make it to the muscle. So that's where IVIG, plasma exchange, and the newer generation of the FcRn inhibitors, and that's your efgartigimod, also known as Vyvgart, is an FcRn inhibitor. Your roxazolinimab, also known as Restigo, is an FcRn inhibitor. Your third approach is to deplete the immune system, to try to damage it such that it can't attack you. And that's where thymectomy comes in. And that's where the oral medications, mycophenolate, also known as Cellcept, azathioprine, also known as Imuran. Some patients are on cyclosporin, some patients are on methotrexate, some patients are on rituximab. Those drugs all fall under this depletion strategies, reduced T or B cell populations. So this is the current treatment landscape, and the clinical trials add to this landscape. Okay, so there are 5 different strategies that the clinical trials take. And so we're going to talk about each strategy, and after 1, we'll pause, and then 2, and then we'll pause. So a strategy is to add to the right side of the diagram. The pyridostigmine is the only drug that doesn't interfere with the immune system and tries to make the muscles twitch better, more effectively. So one strategy is enhance the muscle twitch. Strategy two is to expand the label of existing modulators. Those are the drugs that allow the immune system to stay intact, which try to turn down their activity. Strategy three is to expand the label of depleters. Those are the drugs that damage the immune system. Strategy four is new depleters, and strategy five is new versions of complement inhibitors and FcRn inhibitors, trying to optimize those strategies. Okay, so therapies that do not target the immune system. Okay, so this study right here, this is Pedersen et al. This was from 2021, so this is 3 years ago. Very, very recent in science terms. 3 years ago, Pedersen et al. Figured out that a particular channel at the muscle, the chloride channel, is important for determining the likelihood that a muscle fiber will twitch. And so where are those chloride channels? So here you have a nerve, and in pink you have the muscle. And in the green, you have those acetylcholine receptor channels, the receptors. And pyridostigmine allows acetylcholine to stick around a little bit longer so you can bind to those receptors. And the chloride channels are down here in these little crevices. And so if you block these chloride channels, you may get a muscle to be more readily available to twitch. Might be easier to get that muscle to twitch. And so that's interesting, because what if this is all damaged, right? If this is all damaged, then it doesn't work quite as well as it should. It might be resistant to firing. And if you could reduce that resistance, you might be able to return this all back closer to normal without suppressing the immune system. Now, we know with pyridostigmine, as also known as mestinon, it's not the only drug that we have people on, but we know that it fills gaps, right? If at the end of the day you have double vision, you might take some more pyridostigmine, and that might eliminate the double vision you experience at the end of the day. And maybe you don't drive long distances because the strain causes double vision, right? So there are just nuances to your day-to-day experience where maybe you don't want to suppress your immune system more. Maybe you just want to get a little bit more out of the muscles. And so introducing a second drug that does that might be useful. So there's a company, that company is NMD Pharma, and their drug is Agent 670. And this is really hot off the presses. In the last year, they've published a paper on 12 patients. And those patients had a modest burden of illness, a QMG score of 9. And they found that those patients experienced a modest improvement, a 2-point improvement. That's not a big improvement, but it was noticeable enough to be significant. And when those patients underwent EMGs, their EMGs changed. So that suggested that their way they were experiencing their day-to-day experience was better, and the way we measured the function of their nerves and muscles were better. Now, 12 patients isn't a lot of patients. It's a really small study. But NMD Pharma is thinking about this drug in a lot of different diseases. They're thinking about it in myasthenia, thinking about it in spinal muscular atrophy, Charcot-Marie-Tooth disease. And most interesting is actually down here. Sarcopenia is deconditioning, someone who, by virtue of sitting around and not being as active as they would like to be, they've lost muscle bulk and lost their response times. And now they're stuck. They know that they need to get more muscle bulk, but they're so tired and fatigued that they can't get going. And, we see that in patients who break a hip, and we see it in patients who have been on steroids for a really long time. And so this is a really interesting thought. So NMD Pharma is in their phase 2. They have only 2 sites in the United States, but a fair number of Michiganders happen to be snowbirds, and they happen to snowbird down to Florida. And so if you have myasthenia gravis and you happen to snowbird down to the Miami area, Boca Raton, and you're thinking to yourself, I'm doing okay, but maybe I need a little bit of help at the end of the day or some other similar function, this might be a clinical trial that's a good fit for you. It will not suppress your immune system any further. It's not designed to do that. I don't know anything else about the safety of this drug. I will try to find out next week when I meet I'll try to meet with this company. And I'll keep track of where they are on their phase 2. If their phase 2 pans out, we are going to want to try to be a site for this phase 3. So if maybe this applies to you, maybe it doesn't, but if you go to Florida as a snowbird and you're interested in trying to understand if this might be a good fit for you, that's the contact, Gabrielle Demara at SFM Clinical Research in Boca Raton. Now, a word of caution. The story with CIC1 inhibitors is really early. And what I'm showing you is a diagram of another super promising thought, which is myostatin inhibitors. It turns out that myostatin is one of the proteins that reduces muscle bulk. It takes muscle bulk from you or prevents muscles from rebuilding when they've been damaged. And so it was observed that maybe if you blocked myostatin, you could get people to build more muscle. And what you're looking at is a diagram of the dozens of clinical trials over the last 20 years that have tried to block myostatin and give people more muscle. And the vast majority of these programs have failed. And there's yet another company, Scholar Rock, that's attempting this in yet a different way. And there are companies who are trying to combine this approach with the weight loss medications, because the weight loss medication will cause you to eat less and your protein will drop. And a lot of people on the weight loss medications report that they have lost muscle bulk in addition to losing muscle fat. Fat. And so this is an area of ongoing development, but it's an example of how difficult it is to actually get a drug past the finish line. And so C1c inhibitors for myasthenia gravis is the opening chapter. It's the first study of such an attempt. I would be surprised if ultimately it gets approved. They are not even close to that. They're in their phase 2. It's a 3-step process. But we don't move forward without the clinical trials and without enrollments. And so if this could be an option for you and you travel to the Miami area, I would suggest reaching out. So here we are with myasthenia gravis, and we've added a clinical trial to this right side of the diagram. Medications that do not interfere with the immune system. Currently, we have pyridostigmine, also known as Mestinon, and we've added to it NMD 670 as an interesting potential agent. Okay, so strategy 2. So let's go back to our diagram. So over here on the left, leave the immune system intact, allow it to make antibodies. Those antibodies are allowed to float in the bloodstream. They're allowed to get to the muscle. They bind. And then we're trying to prevent them from doing bad things. So can we expand this category at all of additional medicines that do not damage the immune system, that leave the immune system mostly intact? So there was an attempt at this. The drug is called satralizumab, and it is a IL-6 therapy. So this is a medicine that is available. It's FDA approved, but not for myasthenia gravis. It underwent a phase 3 study, and that was positive. It did identify a reduction in the disease activity with myasthenia. But the thought was that it didn't reduce activity enough to move forward with marketing the drug. So why did it even make sense to ask this question? So IL-6, it plays a role in stimulating the cells of the immune system, the B cells and the T cells. And patients who have myasthenia and acetylcholine receptor antibody positive myasthenia appear to have more IL-6 in their blood than other patients. And the more IL-6 you have, the more significant your disease burden appears to be. And when you treat somebody for myasthenia and their disease burden goes down, their IL-6 appears to go down. So all of that was pretty supportive thinking that blocking IL-6 or reducing IL-6 might help reduce disease burden. And so satralizumab is approved for a disease, NMOSD, but it didn't reduce disease burden enough. So why is that? So we need the study to be published. And it's possible that the immune system is just really complex, and reducing function indirectly may not work for this disease. So that is true for steroids and for complement inhibitors. There are some patients for whom steroids just are not an effective treatment. And there are some patients who will go on eculizumab, also known as Soliris, or ravulizumab, also known as Ultomiris, or on zilucoplan, also known as Zilbrysq. Those are the 3 complement inhibitors. And the drug won't work for them. And it's perhaps 30% of patients for whom the drug won't work. And so for some patients, it may be that you can't just reduce the antibody binding events. So this is some like nitty-gritty basic science. But what this teaches us is in patients with myasthenia gravis, that's the middle bar of each of these graphs, the various molecules that help stimulate the immune system appear to be elevated, and dropping these molecules down appears to happen when you treat the disease. And what you can see here is that you're seeing 5 different molecules, none of them called IL-6. So it might just be that IL-6, knocking down IL-6 was good, but not enough. Maybe you have to knock down more. So this is back to this graph. And there on the left, allow antibodies to bind to target, restrict activity. And we did add satralizumab because in the end, it was positive. You did get a reduction in disease, but not enough. And so that is one treatment approach. And there are other medications that also knock down disease activity, but are not likely to be FDA approved for this disease. This does inform us, if you have myasthenia plus a different disease, we can start to look at how are we planning on treating that other disease, and could we expect myasthenia to improve to some extent? And so even a study that doesn't result in a drug being FDA approved for myasthenia still helps us care for patients, especially those complex patients that have more than one autoimmune disease. And that's a lot of people. Okay, so existing depleting strategies. So depleting strategies damage the immune system, right? That's this category 3, reduce T or B cell populations. Those are the major cell lines that make an immune response. And so, this is akin to knocking out the factory, right? Or taking out the managers. If you don't have managers, the workers aren't going to work. And so those are T cells, right? The T cells are the managers. And a B cell is the factory that makes the antibody. So if the road washes out and you can't get to the factory, it's not going to produce anything, right? So reducing T and B cell populations, there are existing drugs that do this. And we're going to talk about 3 of them that have recently had data come out over the last year and what lessons we can draw from that. Okay. So the first drug we're going to talk about is leflunomide. So leflunomide inhibits something called DHODH, which is important in the synthesis of rump. All right, so what does that mean? It means that when a T cell needs to expand, it doesn't have access to the raw ingredients that it needs to make copies of itself. And so what you're looking at in these diagrams is you start out with a T cell and then it shunts into different directions per whatever the need is. So if you need those T cells to evolve into things that go kill, like wipe out bacteria, it goes one direction. If you need them to go in a different direction where they remember what they've been exposed to so that their response is fast the next time the exposure happens, then they go into a different direction. Well, on leflunomide, you restrict the access that the T cells have to certain raw ingredients, and then they can't create that next cell line. That's what you're seeing down here on the right. And so the immune system just cannot expand. If it cannot expand, it cannot attack. Unfortunately, it also can't defend. And that's an important element of immune system function. And so leflunomide has a black box warning. So a black box warning is a warning that every patient has to be told every time when the drug is prescribed, and your doctor has to specifically watch for bad things to happen from this drug. And this drug causes liver toxicity, severe, including fatal, and can happen rapidly or in a delayed fashion. And so this drug is FDA approved for rheumatoid arthritis. It's sold under this brand name Areva, but it is not approved for myasthenia gravis. You can see why it might make sense, because myasthenia gravis is driven by both T and B cell activity, and drugs like mycophenolate, also known as Cellcept, and azathioprine, also known as Imuran, those drugs deplete T cells, and this drug depletes T cells. So we know that T cell depletion should work, and we know this drug does that. We know this drug comes with risks. Does it come with rewards? And the answer appears to be yes. So this is a study of 40 or so people. It's patients. It is out of Europe. It studied, again, we talk about special populations in myasthenia, right? So it studied patients with generalized myasthenia as well as ocular myasthenia. It studied patients who had undergone surgery for thymectomies and patients who didn't undergo surgeries. So really adding to our knowledge of underserved patient populations with these sorts of studies. And in general, what you're looking at is that the vast majority of these graphs are going down, right? And down means better in this case. So patients who started the study had an average MG-ADL of 6, right? ADL is a measure of the patient experience over the last week, right? Did you have double vision? Did you have chewing and swallowing trouble? Did you have shortness of breath? And you can see them trend down to MG-ADL of 1 by the 12-month period. That 5-point drop on average MG-ADL, that is a really good drop relative to some of the other clinical trials that have been done. And for that to be the average drop is actually a pretty robust response. And so there's no question that there's risk, but there is also potentially reward. And this is a treatment approach that is mimicking the standard of care. The standard of care is mycophenolate, also known as Cellcept, and azathioprine, also known as Imuran. Some patients are on methotrexate. Some patients are on cyclosporin. So this treatment approach would mimic those treatment approaches and potentially with a reasonable reward. The question is whether or not it's worth the risk. And so currently, this doesn't seem like a wise choice because we just don't have the prospective data where you've randomized people and some people are getting placebo and other people are getting drug. But this drug brings home the lesson that T cell targeting makes sense. And the other interesting thing about this drug is it's not a biologic. That means it's not an antibody, which means you could combine this drug with IVIG, or you could combine it with efgartigimod, also known as Vyvgart, or you could combine it with plasma exchange. And that's important knowledge for our really refractory patients. And so this study adds to our knowledge base, especially for special populations. And again, for complex patients that have perhaps multiple autoimmune diseases, potentially gives us an expectation of what the myasthenia could do when we treated that other disease. Okay. The next drug is cladribine, also known as Mavenclad. So the mechanism here, again, is purine antimetabolite. And so what this does is cladribine integrates into the DNA and essentially breaks the process of repairing and replicating it. In particular, it does this to T cells and B cells. Mavenclad is the trade name. And again, this is a black box warning. And the black box warning here is that using this drug leads to increased risk of cancers down the road. So this drug is currently prescribed for multiple sclerosis, and it is for patients whose brain is under relentless attack and other treatment options aren't working. And they're at very high risk of losing their independence and being permanently disabled if a relatively dramatic next step is not taken. And so for those patients, that is the place in the current thinking with multiple sclerosis that cladribine is currently used. The question is, do we need that kind of if all else has failed, rescue option in myasthenia gravis? The answer is we just might. There are certainly patients who are being hospitalized twice a year, who can never get their disease under control, who are resistant to current therapeutic options. And so there is data to date. There's a 2019 pilot study. And the 2019 pilot study was again small, 11 patients. And again, for this study, which is small, a remarkable and rapid decrease in disease burden and a rapid ability to reduce prednisone. So very clearly, this is a risky drug, right? Comes with the risk of causing cancers later in life, depletes both the B and the T cell lines. So your immune system gets significantly damaged. But turning off the attack appears to have benefited this group of patients. And so is there a potential role for myasthenia gravis? The answer is yes. The patients that were tested were refractory. They had already failed many drugs and they had a high disease burden. The approach likely mimics the way this drug is used in multiple sclerosis. And in multiple sclerosis, you end up needing long-term monitoring. You've solved one problem, but increased risk for another. But as you can imagine, independence is threatened and quality of life is threatened, ability to support family is threatened. Sometimes you just have to make the choice that is available to you now. The cladribine clinical trial is emerging. This is a clinical trial that will open sometime soon in the next year. Again, if you're an affected patient, so significantly affected that current treatments are not available or working, then it's a difficult potential choice, but ultimately a potential choice. Okay. Additional existing depletion strategies. So this next drug is rituximab. Rituximab is an antibody, and it is often used off-label. In 2017, there was a study that suggested 55% of the time, people who are writing rituximab are using it off-label. It has been studied in myasthenia gravis. What you're looking at is the NOAC paper from 2022. And unfortunately, in this paper, rituximab was not effective in reducing the burden of myasthenia gravis, as measured by the ability to reduce prednisone. Rituximab is in the guidelines for the management of myasthenia gravis. It is off-label. That means the FDA has not approved it for this purpose, but the guidelines suggest that you should consider it if things are not going well. And in MuSK myasthenia gravis, it is considered the standard of care. This is another black box warning. And so this drug can cause infusion reactions. Those infusion reactions can be delayed and can be fatal. This drug can also result in chronic infections of the brain, a disease process called PML, and can cause chronic infections like tuberculosis or hepatitis C to re-emerge and to damage you. Again, the three drugs we've talked about thus far in this section are depleters. They leave you significantly less able to defend yourself by damaging your immune system so that it doesn't attack you. So B cells go from immature to mature, that's left to right on this diagram. And over on the right side, in the most mature form, then they make antibodies. Down at the bottom of this graph, you see the word CD20 expression. That is the parts of the immune system that rituximab targets. And what you can see is that the cells that actually make antibodies may not necessarily be immediately actively targeted by rituximab. That instead you might be targeting the upstream. The cell has to go through its various phases of maturation before it makes antibodies. And so you might be knocking out the pipeline to get to these cell lines. So in blue, you see a different bar, CD19 expression. And so it shouldn't surprise you that if we have drugs that target CD20, that's rituximab, we probably have drugs that target CD19, and we do. And it turns out that this issue that CD19 might mark cells that actually make antibodies when CD20 does not, that issue is a very real issue. So if you look at the bloodstream and the types of B cells that live in the bloodstream, they are mostly CD19 positive, and they actually don't have a lot of CD20. And if you look in the bone marrow, it's the same story. And if you look in the tonsils and in the spleen, these are all places where immune system cells tend to live. And in each of these places, CD19 is the marker that is predominantly demonstrated. So this is probably more than just a theoretical issue. And we know that some patients go on rituximab and do not do well with it. And it sort of was kind of unfathomable, actually. If the drug depletes B cells, then why aren't people getting better? And this could be the reason that it depletes B cells, but maybe not the right ones. That's an interesting argument. And this diagram kind of tells that very same story, that the actual markers on the outside of B cells at different phases of their life expectancy change. And this diagram tells you that it matters which disease you're talking about. So down on the right, we're talking about myasthenia and B cells make antibodies and antibodies attack. But on the left, in rheumatoid arthritis, B cells make antibodies. Sure, that's happening, but B cells have, as you can see in this diagram in the left lower, antibody-independent effects. So that's that whole IL-17, IL-20, that's that conversation we had with satralizumab. So in rheumatoid arthritis, it's a disease where maybe if you just try to block the chemicals that these B cells are excreting, you might reduce joint destruction. But in myasthenia gravis, maybe it's not working that way. And maybe you really have to target B cells that make antibodies in order to cover patients more robustly. These are theories. The drug that may help us understand these theories is this one. Inelizumab, also known as Uplizna. So this is FDA approved. It's FDA approved for NMOSD, and it blocks CD19. So again, we saw in this diagram, right? CD20 is on the outside of a bunch of B cells, but not all, and probably not on the B cells that are actually making antibodies, but CD19 appears to be there. And we know that because in all of these organs, we see lots of CD19 and almost no CD20. So Uplizna is FDA approved, but while this drug doesn't have a black box warning of significant organ injury, it reduces B cells and does so really robustly, which means you do not produce antibodies, and which means you need to be concerned about infections. So chronic infections like hepatitis B and again, the JC virus. And if you want to get your vaccinations, you got to get them done before you start taking this sort of drug. So this is the MINT trial. It just released results by press release on the 27th of September. And the MINT trial suggests that this drug may in fact benefit patients with myasthenia gravis. And so we have yet to see all of the data. We don't know anything about safety. But if I had to guess as to what will happen in 2025, it's that you're going to start to see some conversation around this agent. And it does not escape my notice that the manufacturer of this agent has sponsored this meeting. So I think that they are anticipating this as well, that they may have a role to play in the conversation around the management of myasthenia gravis. So last drug for us to talk about in this section. So this is megatizumab, also known as TAK-079. TAK-079 is a CD38 inhibitor. So where is CD38? Let's go back to the diagram. CD38 is on these plasmablasts and plasma cells almost exclusively. It's not on the other cell lines. And that's, you can see here, CD38 and CD38, but it wasn't over here and it wasn't up here, right? And it's not down here and it's not over here. So the TAC-079 drug is a CD38 inhibitor, which is meant to deplete these cells that are creating antibodies. And this trial was done. TAC-079 was studied in myasthenia gravis. We were a site for the TAC-079 study, and the company chose to deprioritize myasthenia gravis and not move forward with development. Unfortunately, I don't know why. We have not received the study results. We would suspect that the study results were not as robust as would be hoped. And so does that inform us about potentially the approval of a CD19 inhibitor? It might. We'd like to hear more about what happened with TAC-079 other than it was deprioritized. And we'd like to hear all of the data around CD19. So that was section 3 on market depleters and how they're being thought of as being applied to myasthenia gravis. So strategy 4 is offer new mechanisms to influence B and T cells. So this is influence, not necessarily deplete, though some of them some of these are depleters. So we're going to talk about core pharmaceuticals. So core pharmaceuticals is introducing a agent called nanoparticles. So a nanoparticle is an extremely small particle. And these are small plastic beads, essentially polymers. So what is the purpose of making tiny plastic beads? It's to deliver something. So what would you deliver? You would deliver antigens. Okay, so what's an antigen? An antigen is the thing that the immune system is reacting to. So the immune system had to decide in acetylcholine myasthenia gravis that the acetylcholine receptor doesn't belong there. So it had to make that decision to start to attack that receptor. And clearly that was not an intentional decision, and it was not an expected decision, and it should never have happened. So what if we could turn the clock back and reprogram the T cells such that we undid that decision? Then we wouldn't have to go deplete them. We wouldn't have to go kill them off if we could just demonstrate to them that that immune response is actually misguided. And this is what core pharmaceuticals is trying to do. The science here is, what do you put in the plastic bead? And because the plastic beads are foreign, they're clearly foreign, they don't belong in the body. And T cells gobble up and destroy foreign things. So if the T cells gobble up the plastic beads and destroy the bead, what they're left with is a piece of a cell that we put in the bead. And they're being presented with that piece of cell, but without any inflammation around it. And so that seems to be an important step, because parts of the body break down all the time. You get cuts on your hand, you might suffer a shoulder injury. And yet, and so the T cells have to go clean up all that damage so that you can heal. And they do so without then inciting some sort of massive response against the skin or massive response against the joints. They just do their job. So the theory here is that what has gone haywire, so to speak, is that the antigen, the part of the body, was presented to the T cell in the setting of the wrong style of inflammation. And if you can represent that antigen to the cell without the accompanying inflammation, you can trick it to take it up, you might get those cells to just stop attacking that part of the body. So that is super cool. Whether or not it actually works is a big question. But the audience asked me, what do I see as potentially most promising? And the idea that we could get the immune system to stop attacking people without depleting or wiping it out. That is cool. A word of caution. It sounds like this would be really, really specific and really, really targeted. And that targeting should lead to fewer side effects, presumably, and a more intelligent effect on the body. I'm giving you a black box warning. This is like the 6th black box warning I've given you. This is for a medication called interferon. Its trade name is Tegsedi. It is a really specific drug for the disease TTR amyloidosis, and it modifies how the body makes the protein in TTR amyloid. So it's super specific for reducing that protein's activity. And you would have thought that this protein is only found in certain organs, and we should only ever get side effects if we get any in those organs. And yet this drug appears to be toxic to the bone marrow and toxic to the kidneys. And so exceptionally small molecules have an extraordinary ability to get everywhere. It's like if you release a glitter bomb in your living room, you're going to have glitter in your living room for years. And so exceptionally small molecules get everywhere in the body. And when you expose the body to something that can get everywhere, it's going to have unpredictable effects potentially. To use a different example, radiation. Radiation penetrates the body very robustly and causes unpredictable effects. So the challenge here is you're using these very teeny tiny plastic particles in order to get the T cells to take them up. The reason for the clinical trials is to understand, is that safe or not safe to do in human populations? And you've got to take it through the prescribed stages one at a time. And you're going to end up on the other end with potentially a therapeutic option, as we saw with interferon and Tegsedi, but potentially you're still going to have a conversation of risks and benefits and monitoring and organ-threatening effects. And there is no free lunch, so to speak, no perfect therapy. There are a couple additional treatments, and so I will just sort of briefly introduce these. Another approach to reducing the effectiveness of the immune system is to reduce the ability of the B cells to replicate. So rather than being directly toxic to them, to stop them from overgrowing. This is a clinical trial that Novartis will be offering with Bruton tyrosine kinase inhibitors. You can see that there are existing drugs in this class that have a whole number of side effects. And those side effects have to do with the just sheer variety of places that these inhibitors live in the body. Novartis is the second company to try this in myasthenia. The first company to try it was Sanofi, and they paused their trial because a patient had drug-induced liver injury. So again, there's a unique opportunity to try to treat myasthenia by changing the way that the immune system is functioning and reducing its overactivity, but not without risk. This is the Remagen trial, another emerging study that we'll see in the next year. This is a drug that's approved for sale in China for lupus. It's under investigation in the United States for a whole host of disease states. And it targets, again, factors that make B cells replicate and make them overly active. That's B lyse and APRIL. We'll have to see how this Remagen product pans out in terms of efficacy. We saw this diagram earlier that, so B lyse and APRIL popped up on this diagram. We saw this diagram in the setting of the failure of satralizumab. So we would hope that the Remagen's product may avoid the failures because it's targeting two instead of just one, but we'll have to do the trial to see. There are CAR T cells. This is, again, engineering the immune system to go attack the B cells. This works. It works in oncology. There are these 6 drugs that are approved in oncology. But again, you're going to see another black box warning. That black box warning is for cytokine release syndrome, which is a life-threatening potential reaction that can occur. Again, is there a population of patients where this could be the right step? The answer is yes. Are there newer treatment options to achieve these T cells without the cytokine release syndrome? The answer is potentially. Another approach to treating the disease. Okay. So this section, we talked about additional diseases to add, or drugs to add. Strategy number 5 is new targets or delivery mechanisms for presently established diseases or treatment approaches. So we already have complement inhibitors and we already have FcRn inhibitors, right? That's Alexion's product line, that's UCB's product line on the complement inhibitor side, with eculizumab, also known as Solaris, ravulizumab, also known as Ultomiris, and zilucoplan, also known as Zilbrysq. And on the FcRn inhibitor side, we already have products, right? We have the efgartigimod, also known as Vyvgart, and we have roxazilinimab, also known as Rystiggo. So there are additional trials ongoing and entering in 2025 at our site and others to continue to add to these treatment options, either trials like this one, the MAGIC study with Dianthus Pharmaceuticals, which is targeting complement inhibitor, complement at a different spot. This study through Alexion, which is trying to administer complement inhibitors with weekly self-administered injections rather than infusions. This study with Immunovant, which is again weekly self-administered FcRn inhibitors rather than the infusions that you have with efgartigimod or efgartigimod Hytrulo. And so those add to the conversation to those classes of complement inhibitors and FcRn inhibitors. So to recap, we have new therapies coming to every one of these categories, right? We added boxes to all 4 categories. Our center is involved in a spectrum of these trials, and we do have a site contact in Aubrey Alexander, who is one of my research associates. We would be absolutely delighted to help any patient with myasthenia. I will say clinical trials are never the right first answer. The first answer is, what are you on now? Can we optimize with FDA-approved medicines? But if that's not an option for whatever reason, that's when we engage in the conversation of studies. I do appreciate the time and the invitation.